Okay, I'm going to get started.
Okay.
This is a really great, I wanted to share this kind of change over time. So this is how the patient presented. Any thoughts? Let's see if I can pull up. Yeah, this was just the initial. Yep, I don't know the arterial phase. So there's all of this stranding here, and in addition to the stranding, the vessels are kind of abnormal looking. You can see this is the SMA here. Let me pause really quick so I can. Yes, great. And here you can see the SMA is kind of not normal. There's thrombus here. There's a lot of inflammatory changes and also surrounding the fat with these little reactive nodes. Any ideas in terms of differential considerations that you would put into this, not knowing the history?
Some kind of vasculitis, Nelly.
Yeah.
Small and medium.
Inflammation. Yep. Exactly.
Any collagen vascular disease or connective?
No.
Okay.
There's a splenic lesion. So this, and actually there's other findings here. There's a wedge shape thing here. There's hypodensity here. And the history that I've withheld is that this patient has endocarditis.
Yeah, I was going to say septic emboli.
Yep, exactly. And so that's what this turned out to be. And then this is kind of the evolution of the septic emboli. So here we got an angiogram subsequently, and you can see the SMA is like almost entirely out. But the bowel looks okay. And then this is later they took the patient to the OR, just try to revascularize it, but they found out that the segment was too inflamed, so it wasn't going to be safe to try to bypass the segment. So the bowel looked normal and pink, and so they decided to not do anything. And the patient, did well, and then this was a follow-up after the patient was discharged, and you still see occlusive thrombus, but the bowel looks fine, and it's because this patient has a pretty robust collateral. Let me pull up the arterial. Has a pretty robust collateral right here that reconstitutes the branches, the ileal branches distally downstream, right there.
Nelly, doesn't that have a name?
Rising off the jejunal.
I forgot the name. Is it the archirelon or like there's something about that anastomosis or?
Yeah. No? I don't remember.
I think that's right, Aarti. It's where the GDA and superior inferior pancreatic or duodenal will anastomose, right?
This isn't coming from the GDA. It's coming from so here's the SMA here, and then it's coming from the first branch. So there's a jejunal branch. So what's occluded is the downstream branch. So this first jejunal branch then has this robust flow. So I don't think it's coming from the GDA. Is that right? I forget what the arc of Riemann goes from, but I think this one is still within the SMA like arcade system. It's just supplying from the first branch, and then the middle kind of downstream branches are occluded, but it's able to reconstitute the flow. I will Google it as we review the next case.
I Googled it, and the archirelon does come off the SMA.
Oh, it does. Just kidding.
And it wraps around, but yours is an even longer archirelon, but I think that's what it is. It goes and it applies the splenic flexure area and the marginal artery, and then it loops around and joins the IMA. So it helps if the SMA is occluded.
Oh, gotcha. Okay. I just described the origin and just describe it.
Yeah.
Remember, this used to be a board's question, right? It's been a few years now.
Okay, Roopa, you're up.
Okay. So, okay. Can you see my screen?
Yes.
Okay. So this was an elderly female patient came in for pancreatic mass evaluation. CA19-9 was in the 300s. So not hard to see the findings, but so big uncinate mass, lot of MPD ductal dilatation. This was almost a centimeter. She did have a history of chronic pancreatitis. So what usual differentials would we have given?
MCNs, I mean, this is huge and it's big. So presumably if this is not pseudocyst, then this needs to be EUS'd.
Right.
I think also IPMN, I'm trying to see if the duct is connected to it. And on the post-contrast, I almost felt like it might be connected. But usually IPMN doesn't have a capsule, and this almost has a feeling of a capsule. So
right. So those were kind of the exact same differentials we gave. It's either an IPMN with malignant transformation or she's female, and although MCNs would still be more body tail, this is unusual location wise. And one other thing we also mentioned was like a main IPMN, because the MPD was also significantly dilated. So same conundrum, whether it was obstructed and hence dilated, or by itself it was dilated, we couldn't tell. So they did do EUS. And surprisingly, this actually came back as a myxoid spindle cell sarcoma of the pancreas. So something to remember in the spectrum, I guess, when we see very bright T2 lesions. Looking back, one thing I was reading about IPMNs or mucinous was that you should expect somewhat more nodular enhancing components, which this one didn't have as much. But I don't know how prospectively we could have said anything different. So this is back to Aarti saying that, pathology always trumps everything. So
I don't say that. Actually, sometimes pathology doesn't trump us. Sometimes we trump pathology.
You think
Actually, what I say
I know
is
you're a believer in pathology.
Isn't always the gold standard. But in this case, I feel like I'm not surprised in retrospect, but I wouldn't have, it's such a rare thing.
Right.
You can't bring it up, right? But it does, like you said, look atypical for MCN. It looked atypical for IPMN. So I'm kind of not surprised it's not something weird. And I showed one recently that I thought was an IPMN and turned out to be a cystic neuroendocrine. So that was another one that that we can think about too.
Yeah. So one article, Nelly, can I share screen for just a second?
Yes.
So something I pulled up just to go over these IPMN and the histology of it. So when we say IPMNs, really under the microscope, apparently these are the histologic subtypes of IPMN. So it can be like a pancreatic or biliary type, intestinal type, gastric, oncocytic. So that's one way to classify IPMNs. The other way is how aggressive they are. So it can be from very low grade dysplasia with well-organized glands to very bizarre looking architecture as it goes from low grade to high grade. So that's something I learned is under the microscope, that's how they look at IPMNs. So ours would, I imagine somewhere would be in this category where the T2 bright areas were mucinous because they found the same things, but on their sarcoma stains, all of it was positive also.
Cool. Okay, Victoria is going to intersperse here.
Okay. Wait, so let me start. I guess we can start with this one. It's not a diagnostic dilemma or anything like that. It's just one of the bad things. Let me just tighten it in. So one of the things that is very uncommon is metastasis to the liver, to the gallbladder.
Melanoma somewhere, Victoria. Yeah.
Yeah. So this is like a horrible case of melanoma, which you can see it has peritoneal mets, it has MSK mets right there, adrenal mets, and then very unusual melanoma. So this is interesting because you guys all jumped on melanoma. Here's a liver met. When I was in the Bronx, I think I've seen 3 cases of melanoma the entire time. And the gallbladder mets we've seen, the few of them that we've seen were from renal cell and lymphoma. But since I've been a BI, they're still rare, but we've seen many more melanomas and many more gallbladder mets. Kind of interesting. All right, the next case is is sort of a, this is a little bit of a, this wasn't picked up prospectively, and I can't, it's hard to blame, you know, knowing, you know, it's easy knowing what happened. Does anybody see anything that they would be concerned about or question or raise eyebrows about?
There's something in the left anterior abdominal wall, right?
I say stomach.
Left anterior abdominal wall?
Is that anything, or you were just on a weird slice? Okay, maybe it was just a weird slice. It looked asymmetric on that post contrast.
There's something
But
that
it is an abdominal wall.
Like
Look here.
between, oh, posteriorly, okay. Oh, wow.
Oh, wow.
Another melanoma, because it's T1 bright.
It is melanoma, right? So this is like, I've never seen this before, but this is early stage melanoma, and you can actually see T1 hyperintense signal, and it is enhanced.
Wow.
So like this is not, I don't think this is, the T1 is, I don't think that's pick upable. Even if your eye got caught on it, you'd be like, oh, okay, it's some sort of, you know, just like here, and I just want a little bit of artifact heterogeneity. This is probably the only place where you could conceivably pick it up, because it just stands out so much.
Victoria,
but this is
scroll on
detectable.
the T1 some more.
Very subtle. This is not perspective callable.
That is so cool.
This theoretically you can pick up, right? Because it just stands out so much. But I can't, you know, I think this would be a very difficult call to make. There's no other, here's a T2, sorry.
So how did you end up like figuring out that they have melanoma?
We read the follow-up, and there you go. By follow-up, this patient had also renal cell carcinoma, so he just came back for renal cell follow-up, and when we saw the, you know, post-surgical changes here, figured out what happened, and then just retrospectively noticed it. And I think here, maybe you can see that it's a raised thing. See that? To hypo, to skin.
super subtle.
See that? Super subtle. Oh, I don't think it's callable at all. I mean, again, if somebody would have called this, that would be like call of a decade, I think. But you know, this is like this is not what we use in MAR for. But anyway, I just thought it was cute.
Very cool.
Stop for now.
Okay, Nelly.
This patient had prostate cancer. You can see the lesion here. It's kind of not so good on the T2. It's right there, it restricts. And so the patient came to us for treatment, and we did a spaceOAR gel. What do you think about the location?
Is it in the wall of the rectum?
Yeah, right there. So the serosa is right here, and then then you lose it. And then when you go down, it actually dissects, I think, a little bit along the left. Here's the sagittal. So here you lose the normal colonic wall signal, the serosa, I mean, not colonic, rectal. And so, yeah, this is dissected into the anterior wall. So it turns out it becomes a little bit of a debacle when that happens, because now the rectal wall is up against the prostate. And it takes like a few months for this thing to dissolve. And so then treatment gets delayed, and they usually have to do a colonoscopy to make sure there's not a colonic perforation. I didn't see it kind of extending into the lumen. But now that kind of delays care. So before I would just kind of, go through these cases, but now I'm just a little bit more mindful of the rectal wall to make sure that it's not within the rectal wall. So recently we got this new gel, and it's supposed to help improve before when you injected the gel, apparently all of it went right through, right? And with this new gel, it's supposed to be more viscous so that it's more controlled. And we've seen a couple of these complications that we never saw before. And so I'm not sure if I don't know what's going on, but yeah.
Nelly, my internet was unstable and you cut out for a second, but I have a question for you. I don't know if you mentioned this, but do you think that this is necessarily a bad thing? Because I had a case like this and I showed it to some friends at UT Southwestern and they told me that this was actually okay.
Yeah, when my understanding was that this is not okay because it now the rectal wall is up against the prostate, and so the reason they put the spaceOAR gel is to protect the rectum from the prostate so that they can radiate without reducing and reduce the risk of proctitis, radiation-induced proctitis. And so now the rectal wall is like up against the prostate, so that increases that risk and completely, like the benefits are. I mean, in fact, the risk may be increased now, right? Because the rectal wall is up against the prostate and will be within the field, radiation field. So, I mean, that was my understanding based on the discussion that I had.
And we think that it's part of the rectal wall, like that this is in the rectal wall. So like that would be the
yes, I think, yeah, because up high it looks fine right here, right? Up by the mid base is fine.
Right, but I mean, you're also like even in the mid part of it, you're saying it's in the rectal wall, like dissecting the layers of the wall.
Yes, that's what I think.
Okay.
What do you all think? I mean, does this not look
so the
like
mucosa is still like
intact?
Yeah.
Yeah, okay. But I think it's in the between the serosa and like in the middle.
But my friends at UT Southwestern were just telling me, and I didn't think about the point that you're saying, which is like it's bringing it into the radiation field, but they were just saying like this is inert gel and it doesn't damage the wall and it's fine.
I think that's kind of what our urologists told us too, because when we started seeing these, they said it's inert and they'll just watch it in 6 weeks to see if it goes away. The main thing, like Nelly said, was they just needed to make sure there was not a perf, which because most of these are interstitial infiltrations, they don't end up being perfs. So our urologist didn't seem to be too concerned either.
The main thing was that it delays radiation therapy for us.
Cool, got it. Thanks, Roopa.
Okay. So this is sort of a companion case to what I showed earlier. Can you see my screen?
Yes.
Okay. Young male who came in from outside hospital for pancreatic mass evaluation. And by the time we saw the images, there had already been a biopsy. So we kind of know what it is, but prospectively, what would we have called this? Here's T2, here's pre-T1. CA19-9 was not up. No pancreatitis, no syndromes, nothing.
Maybe neuroendocrine versus
some
other unusual tumor.
Right. Neuroendocrine was my thought too, because those can happen in younger ages. We thought of SPEN for a minute. He was young, but those are still more in the tail. They can look heterogeneous like this. So for primary pancreatic things, those were the two things we thought of, and that was kind of the differential we gave. But
one thing about SPEN, when it's not enhancing centrally, it's usually from hemorrhage. And so the T1 being not having hemorrhage in it is just a little less
against. Okay. Surprisingly and unfortunately, this ended up being Ewing sarcoma of the pancreas. So both these cases kind of came back to back, two sarcomas with unusual features. So something to keep in mind when we don't see typical adenocarcinoma-like features or one of the MCN or neuroendocrine even, something to think about is to keep mets to the pancreas from somewhere in the differential and primary sarcomas of the pancreas. So both these were primary pancreatic sarcomas.
I have a question for you, Roopa. So now having seen these, would you put it in the differential? Because I had a string of sarcomas like, I don't know, 6 or 7 years ago.
Yeah.
And then I haven't seen any.
I know, that's what I'm saying. It's one of those we forget, right? And then every now and then it'll come back and surprise us. So,
but so in the future, if you saw this case and it was a young patient, I think it's reasonable to put sarcoma.
I think it is too, now that we've seen a few. Yeah. So two unusual cases.
Okay, Victoria.
Okay, can you hear me?
Yes.
Yes.
Okay. All right. Hold on. This one is just it's not a eye test or anything like that, but it's just a very interesting, a good example. Patient had ERCP and then developed cholangitis. You can see that there's actually, air.
Victoria,
You
for
can see that
me,
there's-
the images are a little bit like not contrasty enough. Is anyone else seeing that? Or, yeah, that helps more. Thank you.
better.
Yeah.
I think it's a screen setting, but it's fine. You tell me like whatever. Anyway, so you can see patient has cholangitis, patient has an abscess, and this is something that is a complication of cholangitis and abscesses, and this is thrombophlebitis. You can see that the portal vein is not only thrombosed. Sorry, is this okay? Like in terms of zoom?
Yes.
Yeah,
You
that's
can
good.
see that there's also wall thickening right here, and heterogeneity, and you can see that so this is not just acute thrombosis, but because you see the hyperemia and thickening of the wall, this is actually thrombophlebitis. And then a few days later, patient had an MR here. Now there's an interesting finding, which wasn't there on CT. And now you can see that there's air in the abscess. You see that? So now you see the black areas that become a little more pronounced on the second echo. So that's from air. And
Victoria, in the setting of a stent, does that mean anything though? Like, couldn't it just be from the stent?
This is an abscess. So you're not right. So
But it's communicating with the biliary tree.
And
like it's like a biloma.
No, it wasn't. It's an abscess. No, you shouldn't.
Victoria, on the very first one, did it look almost expansile? I was thinking, is it some sort of a TIV-like thing? Because it looked like there was soft tissue.
Right. So this is acute, acute thrombus can be expansile.
Okay.
And sometimes it's hard on a single phase CT. Like if I didn't give you anything else, it would be difficult to for sure say like for this image is a TIV. But it's a clinical context, right? We have cholangitis, we have an abscess. And
right
the
there,
wall
I feel like you can see the bile duct also communicating with that biloma.
It's not biloma, it's an abscess, right?
Yeah, right? I guess I would call it like a infected like exploded bile duct kind of abscess. So I do think it's related to the cholangitis and infected, but the air, I think, could be communicating with that bile duct that communicates with this thing that came from the biliary tree.
I haven't seen that in the literature. It just, I've never seen the discussion of liver abscesses communicated, like in the setting of cholangitis, there's communication. They're just feeding of bacteria, but whatever it is, it is an abscess with air. And here's a MR done a few days later. You can see that there's absolutely no enhancement of the thrombus. And you can actually see that the enhancement of the wall is getting better. The patient is recovered, but it has, now developed cavernous transformation here. Unfortunately, a little motiony, but you can actually see there. But we don't have the main portal vein anymore. We just have a collection of these vessels here, which is cavernous transformation. All right, let's see. This is a acute case. The patient came in for defecography, and the tech did not realize that the gel was placed not exactly where it was supposed to go, and did the entire study. And then a few days later, a patient came back, and then now we put in the gel where it's supposed to be. And I just want to show, good for patient, but unfortunately for us, she doesn't have any major mucosal abnormalities and intussusception or anything. But you can see how without rectal gel, the rectum is collapsed. First of all, it's more difficult for the patient to do the adequate Valsalva maneuver as opposed to when you have your rectum distended. And you can see that, you know, if she was doing any intussusception situation, you would see it here with expanded rectum, and there's no way you can see it here. There's just a cute example of why we put gel into patients' rectum for these cases. And then my final contender is this case. And she's a young woman, I think. Not sure that's relevant or not, but you can see that there's very kind of aggressive looking liver mass. This is pre, and this is arterial phase, and then here's our portovenous and late phases. And you know, there's not much you can say about it other than this, you know, kind of large partially necrotic mass, and really needs to come out. It doesn't have any features specific to anything. They did an MR a few days later. You can see, again, like very irregular central necrosis, kind of irregular peripheral, whatever. You know, so obviously, you know, here we're thinking about neoplasm first and foremost. Sorry about all the noise I'm in the reading room. Anyway, so you know, in these cases, patients need to have pathology. So this was a atypical solitary fibrous tumor of the liver, which is something I've never seen before or since.
Wow.
Looks so aggressive, Victoria.
Roopa and I were texting an angiosarcoma. I've never
Big
seen one.
vessels
Right, I mean,
going.
Yeah.
Yeah, and that's right. No, like this looks like a neoplasm, right? Like whatever it is. And I agree. You know, angiosarcoma is a good thought, or some sort of very aggressive HCC. She's young. She has no, you know, potentially some sort of very aggressive form of fibrolamellar. But this ended up being atypical solitary fibrous tumor, and this is from 2015. So
I guess
multiple years.
retrospectively, Victoria, is there progressive enhancement we saw from the arterial, like that rind kept getting thicker and thicker on the more delayed images? Not
I
really.
think so.
Not really. Yeah.
And that doesn't really help with like few cases of angiosarcoma that I've seen, especially when they're not like super you know, like when they're a little less different, like not a little more differentiated. I guess you can actually, they almost sometimes look like funny hemangiomas, where you can actually see parts of it that progressively enhance, and you can be kind of like, am I looking at some weird hemangioma? But so I wouldn't trust that. But anyway, it was just a crazy case.
Victoria, one question. So you said atypical solitary fibrous tumor, and I know that a minority can be called malignant. Is it, they said it was like on the sort of spectrum to malignant, like she needs to have like close follow-up and there's risk for metastatic disease?
They have been following her up. Let me just double check.
Because I do think that these have like a surprisingly, like there is a maybe 20% rate of like recurrence and or mets on SFT. So there's a spectrum from benign to malignant.
Right, I'm just looking. I'm opening up pathology. So the patient. Oh, she has mets. So she, as of 6 months ago, she has a lung met, which is path is solitary fibrous tumor consistent with metastasis from previously seen liver primary. So this did metastasize.
I'm looking on online, and it says if they're greater than 10 centimeters, they tend to be malignant, higher grade tumors, more usually in older individuals, and have a poor prognosis.
All right, so the original pathology in 2013 said atypical solitary fibrous tumor, indeterminate malignant potential extending to within 0.2 centimeter of parenchymal resection margins. Biliary and vascular margins were negative. Background liver, non-specific inflammation, fibrosis due to mass effect from tumor. So that's original resection. Then, but 4 years later, she had right lower lobe lung resection, which metastatic solitary fibrous tumors. So let me grab some of the chest. CT. So the December. Okay. Give me a second. I mean, I'm sure it's going to be just very non-specific appearance, but I'll pick it up in 1 second.
While you're doing that, I Googled it and it's 15 to 20% are malignant. And even benign SFT have indeterminate malignant potential. So all of them need to be followed up.
Right. So I can't, let's see. I can't open it up. It's refusing.
It's okay, we believe you.
Well, I'm looking to pass and for whatever reason, no, it just won't open up the chest. It will open up the abdomen, but not the chest for some reason. Anyway, but these are resected. So, something is happening. Yeah, hold on. So they look like tiny little. You can see these.
I think there was a slightly
Small
bigger one
logo.
left. Yeah, it left. If you go down, down, right there,
Oh yeah,
next to the vessel. Yeah,
I think that's what they biopsy. Yeah. So yeah, so that was
Cool.
an interesting case.
Okay, Nelly.
That's all I have.
Thank you.
This patient came in with right lower quadrant pain, and patient has a acute case of, where is it? Right there. Appendicitis, appendix is dilated, appendiculith, inflammatory changes. And then in addition, there is this adnexal mass. This was resected, and it came back as struma ovarii tumor, and it was a nice refresher. So struma ovarii tumor, 10% of cystic teratomas are struma ovarii tumors, and I found out that in order to qualify as struma ovarii tumors, it has to have at least 50% thyroid tissue in the specimen. And patients can show signs of thyroid toxicosis because of the thyroid tissue. This one was found incidentally, and it's just a type of teratomas. I don't know that we can distinguish it. There's not unique imaging features, but it's just a nice refresher of struma ovarii tumors.
Cool, Nelly. I guess the enhancement retrospectively is because there's intense like thyroid tissue in it, right? Is that why it's very avidly enhancing? Nice.
Cool. And it looks like these are also benign to malignant. Nelly, do you have more, or do you want me to do mine?
I can have more, or
okay. I'm going to show
not.
2 at a time and then go back to you. Is that okay?
Sure.
Okay. Okay. This is my first case. You can see that there's something going on with the patient's bowel. And there's a couple of, so there's a bowel obstruction, and then there's a couple of additional findings. One is on this image.
bony lesion from the right iliac.
Oh, nice. That's not the lesion I'm talking about, but maybe there's an osteochondroma. And then there's another finding here. And it's not part of that bony lesion. But okay, the main extra lesion is I'm going to scroll through it back and forth here.
Is that something in the mesentery, Aarti?
Yes, exactly.
Okay, like a hyper enhancing.
Yep. So there's that.
Or something.
Exactly. So actually that was the point of transition of the bowel obstruction. You can see the bowel is dilated and then it goes by there. It gets nicked by this desmoplastic reaction from the serotonin that's being released, and then it's decompressed. And so if you're looking for a carcinoid, you go to look at the bowel and there's probably—
Oh, there's a nodule there. Yeah.
Exactly. Enhancing nodule here, which we don't always see, but anyway, so just a reminder, bowel obstruction, usually is from adhesions, prior surgery, but it could also be from a carcinoid. So always look carefully at the mesentery.
Nice.
When they went in, if they don't see the primary, you don't need to go, you don't definitely need to find it. You don't need to go do a dotatate and look for the primary. They basically, when they go into the OR, when they go to the nodal mass and resect it, they then go and look at all the bowel that it's coming from and run their fingers along the bowel. And there's usually multifocal tiny neuroendocrine tumors. Okay, this one is the next one. What do you guys think about this liver lesion?
Is there a coronal? It looks tubular.
Yeah, we thought it looked almost like here. It almost to me looked like a serous adenoma, but in the liver. But I don't know any lesion that's kind of like that. So, but it looked kind of tubular, multicystic. This is the coronal.
Something in the IPNB spectrum.
Exactly. That's what we were thinking about. We were pretty convinced about that. It was read at an outside hospital. So we were just looking in retrospect and thinking yeah, we definitely would have thought IPNB. In retrospect, is there anything else we would have done to explore that further?
EOVist.
Yeah, that's my question is would you guys have recommended an EOVist for this?
Probably.
Or would you just feel confident IPNB?
We did one and it helped, so probably would have done EOVist.
Okay, good. So we did, at the time, EOVist was not done. We only read the post-op scans, but anyway, this was very interesting. It turned out to just be hamartomas and peribiliary cysts. So I do think in retrospect, an EOVist would have helped us. If we didn't see it communicating, we might have suggested. And I guess I just wanted to show this here to show that biliary hamartomas aren't always just, fairly well-defined. They might even be tubular and multicystic looking.
All the peribiliary cysts we've seen, Aarti, they're kind of lined up along the bile ducts, and patients usually have some kind of chronic liver disease also.
I know. That's what the path said.
Yeah. Yeah, I agree.
So, I mean, they did a localized resection. It was a benign finding, and we do have an post-op EOVist, and actually, there's no issues with the biliary tree, but it was very interesting. Okay, I'm going to stop sharing, Nelly.
Hey.
Oops, hold on. How do I stop sharing?
This is the patient who presented with this. So obviously a mass in the endometrium. Patient also has a history of breast cancer. And then now, this. So then this is resected and came back as endometrial cancer. And then had follow-up. At that time, there's all the little bit of dill here on the right.
Did they have BRCA, Nelly?
I forget if they had a genetic mutation, but they must because patient has multiple cancers. So then we just surveillance after hysterectomy for uterine cancer, breast cancer, and she was I think on, let's see, carboplatin therapy after the THBSO. Anyways, so that we see this in the liver again. And then came back for follow-up. We said no evidence of recurrence. And then we see this dill.
Is it like beaded?
Yeah, what's going
It's
on?
like coming and going.
Something, right? Yeah.
Yeah.
So we just remarked on the dill.
And then the like CBD is
yeah.
also undulating. And like
Yeah.
dilated.
And then patient came back and had this. This was cholangio.
Wow.
So if you look back, this is more of the remote. There's the dill. And you can see it right here, barely right there at the CBD. I don't pay very much attention to the CBD on CT, and now I do. It's right there, and then on the subsequent one, it's right there. There, and then that Aarti, you mentioned the undulation. This is right here. Right there.
It's so clear in retrospect.
Yep, exactly. Yeah. So, and there's this.
Cool. Okay. Hold on. Okay, I just Googled it. I've been doing a lot of Googling today, and it said BRCA-associated breast and ovarian cancer syndrome has an increased risk of developing multiple other malignancies, including cholangiocarcinoma. So, interesting. Okay. Okay, this is my next one. What do you guys think about these liver lesions? I'll show you the coronal too. So there's like an enhancing one here. There's this one here with this nodular enhancement. There's that one there. There's another one here. The patient has a history of lung cancer. So we're reading a lung cancer malignancy screening. So there's this one, maybe some dots of enhancement. This guy here.
I mean, I think hemangioma is definitely a consideration, and I would probably want a MR.
Good, excellent. That's basically what we said. And this is the MR.
They don't look like hemangiomas.
Yeah, exactly.
Not typical hemangioma.
I guess the teaching point here is that some metastatic disease can mimic hemangiomas, so we shouldn't just jump to the conclusion. Although, in this case, another clue that we had like this, I mean, I would have almost said like it's most likely a hemangioma, but it only had one nodule. But the other big clue in this case for us was that they had a prior exam from a couple of years prior, and they looked, the lesions looked quite a bit bigger. But on this exam from a couple of years prior, we said that most of these were hemangiomas. Like that one, we said, okay, like these are probably a combination of cysts and hemangiomas, not definitely, lung cancer mets, which I think is reasonable. But they ended up growing over a couple of years, and then the MR shows that they are mets. So just be careful. Some mets can look like hemangiomas.
Wow.
Okay. Here's one more. This, there's a chest. So this is the chest, anterior mediastinal mass. We talked about this a couple of weeks ago, the like 4 T's, like could this be a thymic carcinoma, thymoma, thyroid tissue, terrible lymphoma, or teratoma? And then in this patient, they also have something in their liver. Any thoughts?
Was there any definite soft tissue in that collection or structure? Because this could
Nothing?
just be hepatic hydropericardium.
Good thought.
Scroll there. It looks like there's some soft tissue to it. So is that like heterogeneous appearance of the liver, like metastatic disease, or is it going to be
Yeah,
like
so I'll
heterogeneous
tell
because
you
it's
in the end, the liver was metastatic disease
Yeah.
from this mass from the chest.
Mhm.
But it took us like 7 different biopsies to get the diagnosis. So it was like this conundrum. They basically biopsied this mass multiple times. They used ultrasound. They targeted soft tissue areas. It wasn't that hard of a thing. And most of the time they got blood, and they got a lot of blood. Like after they did the biopsy, it was just gushing out blood. And they ended up having to gel foam it. And then they eventually put, IR did this, they put Dermabond into it, into the mass and into the hole, and to try to stop the bleeding. And it all came back non-diagnostic, and it basically came back blood. Then they biopsied the liver, and it came back normal liver tissue and blood. Then the IR doc was like, did I literally biopsy the one piece of normal tissue in this entire liver? So anyway, they went back and biopsied it again, and finally came back angiosarcoma. So this was, we think, an angiosarcoma that arose in the chest, in the heart, maybe from the right atrium or ventricle, and then extensive metastatic disease in the liver. We have had another case where we tried to biopsy an angiosarcoma multiple times in the liver, and it took us a long time. So my perception is that these can be tricky to biopsy because there's so much necrosis. They're vascular tumors. They rise from vessels. They're very aggressive. They have very poor prognosis. And maybe there's so much necrosis that like, it's hard to get the actual angiosarcoma cells. You're getting a lot of the bleeding and the blood and the necrosis. Okay, Nelly.
So this was a patient who came in with abdominal pain, and we don't have IV contrast because of the shortage. And so what do you think?
Lipoma in the small bowel.
Lipoma in the small bowel. Which
oh, never mind. I think I was faked out by.
Okay.
Is there a stomach mass with lymph nodes?
Stomach mass with lymph nodes. There's, yes.
Like
so I see the lymph
pylorus
node.
antrum. Yeah.
Pylorus antrum.
They're just thickening.
I think it might be thickening.
Okay. There are some ugly nodes though around the D1, D2.
D1, D2. Yes.
Yeah, that.
This chunky one, right?
And then is there a pancreatic head mass?
Pancreatic head. I miss contrast so much. You don't understand.
I know.
I've been looking at these non-con CTs, and I'm just like, oh, God, what am I missing? So the finding is right here.
Oh, there's a colonic mass.
Yeah.
Nice. Is that why you showed the coronal, Nelly?
Yes.
Okay.
I think you see it better on the coronal, but
nice.
There's a lot of little motion, but you can see it right there.
Oh yeah.
And there's the fat is a little dirty, and there's a few nodules, probably little tiny lymph nodes there.
Nice.
Right there, and then the big one that we saw right there. So stay vigilant despite this contrast shortage.
And especially, I feel like a lot of colon cancers, I see the node first. So that's like.
That's true. Even the cecal ones, the nodes draw your attention.
Okay, I think this might be my last case. Oh, this is, okay. So this patient underwent, had surgery, they had trauma, they had a acetabular fixation. And any findings, thoughts?
Intramuscular hematoma.
Yes, good. So expansion of the left gluteal muscles compared to the right. So always look at the muscles. Anything else?
Is that focus at like hemorrhage, or is that bone fragment?
Extrav or something?
Yeah. Good. So it looked really bright, but it looked weird, and that we didn't see any vessel going in and out of it. So basically what we did was measured this thing compared to the blood pool and then compared to the bone. And this thing and the blood pool both were 270, the bone was 380. So we said that there could be a possible pseudoaneurysm. And this was a single phase study, so they ended up getting a CTA. So this is the CTA non-con first, and we can actually see that there is a hyperdense collection now in the gluteal muscles. And then going to our arterial phase, our blush is gone. So basically we saw it rupture. It actually then, but because it ruptured, it tamponaded the pseudoaneurysm. So the pseudoaneurysm is now gone. The patient didn't lose too much blood, their hemoglobin was stable. So they basically just watched it conservatively. But so anyway, take home point, if you see, if you see a hematoma, look carefully. If you're concerned, like this could be a bone fragment, it would have been more ideal to have the non-con first, but on the CTA, make sure you get the non-con first too, and call the team. Okay.
This one we missed contrast, right?
Yeah. Yeah. I mean, this one these ones we had contrast, but
Right.
Yep. Nelly, do you have any more?
I do, but I mean, it's nearly time. Should I just hold off for next week?
Sure, or you can show one.
Okay, I'll show one. This was a prostate MR, and there's a lesion here in the right mid-peripheral gland, and it restricts right there. It's our ADC map. And just like the other one, the other case, you just keep looking.
What's that like big thing coming off the bowel?
Yeah, what is that? Here, let me show you. Here's our small field of view.
It's like a really thickened segment of bowel with, wait a second.
Yeah, so
Going in two different
here's
directions.
so here's
Oh, it's a
the
fistula.
rectum, and then it's a little bit kind of redundant, and then this is a continuation of that. So the sigmoid.
It looks like really thickened from maybe chronic diverticulosis or SCAD with a fistula going between the sigmoid and the rectum.
The sigmoid and the rectum.
See, there's
like
like
right here, right here. Yep, I see it. Yep. Yeah, so even though the imaging was done for prostate cancer, there's like a lot more going on. So this turned out to be rectal cancer or sigmoid cancer, colorectal cancer. So it was a twofer. And as Aarti alluded to, there's probably right there a fistula. Anyways, keep looking.
Cool. Okay. Have a
Thanks,
great week,
everyone.
guys.
Thanks, everyone.
Bye.
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 Nice cases.